Hello everyone, welcome back to Podcast with Khurram. Today we are diving deep into one of the most fundamental yet clinically important topic like refractive errors, especially myopia and hypermetropia. Most importantly, how they relate to the squint. So let's learn more about refractive errors from Dr. Khurram. Hello sir, how are you?
Yes, I'm fine, and I hope you are doing very well too. Yes, you chose a very basic topic, refractive errors, but you are very right that the refractive errors, the knowledge of refractive errors is very important clinically. So let's start.
So sir, let us know what are refractive errors and teach us refractive errors in different ways.
Yes, Dr. Kashmala, refractive errors, first of all, we have knowledge about the normal eyesight or normal vision or the normal eye, which is called the Emmetropia, right? So it's all about the light rays. It's all about the length of the eyeball. It's all about the power of the cornea. It's all about power of the lens, right? So, Emmetropia is a normal vision or normal eyeball. So what is normal eye or what is normal vision or what is Emmetropia, right? So Emmetropia is when the light rays, for example, if you are sitting before me and the light rays are coming from your body and they are entering in my eye, they are crossing cornea, they are crossing aqueous humor, lens, and these light rays which are coming from you, they are focusing on the retina. So if these light rays are focusing exactly on the retina, on the surface of the retina, that is called the normal vision. And that state is called the Emmetropia. So now refractive errors, these are errors. For example, in refractive errors like myopia and hypermetropia, it means that the light rays is not focusing on the surface of the retina, right? Either the light ray is focusing in front of the retina or it is focusing behind the retina. So if, for example, light rays is coming from the infinity and it's not focusing on the surface of the retina, either it is focusing in front of the retina like myopia or it is focusing behind the retina like hypermetropia. So if the light rays is not focusing on the retina, this is called the refractive errors. And now let's discuss myopia. Myopia is a refractive error, which is progressing refractive errors. And researchers said that in 2050, half of the population of the whole planet will be myope. So myopia, we will record a detailed video on progression of myopia. So the basics of myopia as a refractive error is, for example, remember that as I said that in refractive errors, the refractive errors are all about the length of the axial length of the eyeball, right? So if the axial length, what is axial length? From anterior surface of the cornea to the retina, this length is called the anterior posterior length or axial length of the eyeball. So for example, if we talk about the myopia, the axial length will be increased from the normal, right? The normal axial length in adult, right? In a normal eye, it's 24 millimeter, right? In normal eye, in emmetropic eye. But if you talk about the myopia, the axial length will be more than the normal, right? Increased axial length or increased anterior posterior length of the eyeball, right? So this is one sort of, or one kind of myopia, right? So if we talk about more about, myopia, if your cornea, cornea is like a curved surface, the anterior curved surface, right? Transparent surface. So in myopia, the power of the cornea or the curvature of the cornea will be more steeper. Your cornea will be look like this, the steeper. So this steepening, this curvature of the cornea will increase the power of the cornea, right? So increased power can cause myopia as well, right? So corneal curvature, the increased corneal curvature can cause myopia as well. And the third thing is, the power of the lens, right? The crystalline lens, the biconvex structure inside the eyeball. So if the power of the lens or the crystalline lens is increased or more than the normal, this can cause myopia as well. So these are different types of myopia. So if anterior posterior length of the eyeball is increased, if the corneal curvature is increased, or if the power of the lens is increased, these three different sort of issues inside the eyeball can cause myopia. So due to this increased power of the lens, due to this increased power of the cornea, or due to increased anterior posterior length or axial length of the eyeball, when the light rays will pass through the myopic eye, the light rays will converge in front of the retina, right? And this condition, this state of refraction in which the light rays are focused in front of the retina due to these issues, right? This is called a myopia. And if we talk about the different complaints of the patient in myopia, the first complaint is blurred vision at the distance, right? Patient will more, blurred at distance. And when the myopic patient will look at the near vision, that will be totally fine, right? So the major complaint about myopia is the distance vision is blurred and near vision is clear, right? Along with that, the patient will feel headaches, right? Because the vision is totally blurred. If you are a school going kid, or your school going children, then the whiteboard or the blackboard will be blurred, because the distance vision is already blurred in myopia.
So you said major complaint is in myopia is that the distance vision is weaker but near vision is clear. So how? What is the reason?
Yes, it's very important question. I appreciate. You said that in myopia, distance vision is blurred and near vision is clear. Why? Right? So remember, the myopia is also called the nearsightedness, right? And hypermetropia is also called the farsightedness. There is a logic behind that. And what is that logic? What is that reason? Remember, whenever I look at a near distance, like at this near distance, at this working distance, my eye has to increase its normal power. Whenever either he is myope, or it is hyperope, or it is normal eye or emmetrope. So if anyone want to look at the near distance or the reading material, he has or she has to increase its refractive power in any way, right? And as I said already, that in myopia, the power of the cornea or the power of the lens is already increased. So this is the advantage, or this is the edge to the myope patient, right? So in myopia, the refractive power of the eyeball in terms of cornea or in terms of lens is already increased. So that's why myopic patient can read the near vision very clearly, but he will very disturbed or blurred at distance. So that's why the myopic patient is also called, or the myopia is also called, the nearsightedness, because he is looking the near distance very clearly.
Very well, sir. Can you please tell us the treatment and management options of the myopia?
Yes, there are different mode of treatments or mode of management in myopia. Like we have the option of spectacles or the glasses. We have option of the contact lenses, and we have option of the LASIK surgeries, as we have discussed in the previous podcast. So, but remember that, as I said, that the light rays are focusing in front of the retina. So we need a specific lens which can diverge the light rays, right? And the diverging lens is the minus lens or the concave lenses. So either it is glasses or it is contact lenses. We have to provide the concave lenses or the concave power, the diverging power. So the converged light rays right now in front of the retina can diverge and focus on the surface of the retina. So this is the basic mode of management or treatment in myopia, right? So if we talk more about the mode of treatment in terms of spectacles or the glasses, so let me be very clear. The most important and the most critical thing during subjective refraction is myopic correction. Remember this thing. The biggest mistake we ever made during subjective refraction is when we correcting myopia, when we are prescribing minus or concave power to the patient, right? Because the reason behind that is, when we prescribe minus lens, right? So minus lens gives a patient that the vision is getting clear slowly and progressively. But if we overcorrect that myopic patient, it will cause the minification of the the letter of the optotype. As you are increasing the power of minus, or as you are increasing the power of concave power to the patient before the patient's eye, it will cause very a clarity, right? But it will cause if you overcorrect that myopic correction, it will cause the minification. So that minification will cause the patient will get more clear and more specific to read that optotypes. So remember that overcorrection in myopia is disaster, right? So if we overcorrect the myopia, the light rays will go behind the retina, right? And in which refractive error light goes behind the retina? Hypermetropia. So when patient will be overcorrected in myopia, it will cause hypermetropia. And very well that in hypermetropia, the patient will exert accommodation, right? And this is the disaster. Your patient never use accommodation in spectacles. If your patient is having spectacles, if your patient having the best correction, and still he or she is accommodating, then this is not a good thing. This is a wrong prescription, right? So take care when you're prescribing minus or concave lenses to the patient, right? Do not overcorrect that myopic patient while subjective refraction.
So you explained myopia very well. Let us know about hypermetropia and how it relates with the accommodation.
Yes, before learning about the hypermetropia, you said very well, the accommodation. We have to have a brief knowledge about the accommodation. And what is accommodation? It is concerned with the crystalline lens. as I said, whenever we look at the near distance, our lens has to increase its normal power, right? So the normal power of the crystalline lens is 15 to 17 diopters physiologically, normally, right? But when we accommodate, or when the lens accommodate, that power of the lens will be increased. The lens will be more convex, biconvex lens, right? It will increase its power. So that increase in the power of the lens is called the accommodation. And this accommodation works very well in hypermetropia, right? As I said, if you talk about the hypermetropia, right, in contrast with the myopia, right, hypermetropia, as I talk about the anterior posterior length of the eyeball, in hypermetropia, that anterior posterior length of the eyeball will be decreased than the normal, right? If total eyeball length is 24 mm in adult, right, that will be 23, right, or 22 or 21, less than the normal, right? And if you talk about the corneal curvature, so in hypermetropia, this is cornea, so this is steep. In hypermetropia, the cornea will be more flatter, right? So it will decrease its power. So either it is, the cornea, either it is lens, the power will be more less, right? The power of the lens will decrease, or the power of the cornea will decrease, or the anterior posterior length of the eyeball will get decreased. So this is called the hypermetropia. And if you relate this hypermetropia with accommodation, as I said, the power of the whole eyeball is less than the normal, right? In terms of cornea or in terms of lens, the power is less than the normal, right? So we have decreased plus power or less plus power, but there is a mechanism in the eyeball which is called accommodation, which can increase the plus power. So in hypermetropia, the plus power is decreased, but we have a process, we have a mechanism, we have a phenomena inside the eyeball which is called accommodation, which can increase the plus power. So if I have hypermetropia, which is actually the decreasing plus power, I have accommodation as well, which can increase the plus power. So they will the balance. So I will, as a patient of hypermetropia, I will use accommodation, and while using accommodation, I will increase the plus power. So my distance vision will be very nice, will be very clear. Why? Still I am having diffractive errors, but my distance vision is very clear. Why? Due to accommodation. Because I am having less plus power in terms of hypermetropia, but I'm using my accommodation to increase that plus power, to compensate that plus power, or to overcome that plus power. So I can see the distance vision very clearly, right, as an hyperope, because I'm using accommodation. So that's why as I'm enjoying my distance vision very clearly as an hyperope. So that's why hypermetropia is also called the farsightedness, right? But my near vision is very blurred. So when we look at the near, right, I have nothing to accommodate. The plus power is already used at the distance. So I have nothing to increase my plus power. Right now, I have no plus power to look at my near vision clearly. So that's why my near vision will be blurred, will be worst as hypermetropia, right? If I'm hypermetrope, my distance vision will be very clear because I'm increasing my plus power, which is called accommodation, and I have used all the accommodation. I have wasted all the accommodative power, plus power at the distance. So now my distance is very clear and my near vision is very blurred. Why? Because I have already wasted my plus power at the distance, which I have to use at the near vision. So now let's discuss about the process of accommodation in emmetropia, hypermetropia, and myopia. Remember, process of what is accommodation? Increase plus power of the lens, right? And I am emmetrope, for example. Assume I am emmetrope, and I will use my accommodation just at the near. Whenever I will look at the near distance in my reading material on my phone, I will use accommodation. I will not use accommodation at distance as emmetrope, as normal person, having normal vision, right? But if I am, hypermetrope, having decreased or less plus power, then I will use accommodation at distance to see that distance vision for vision clearly, right? And my near vision will be worst, right? And if I am a myopic patient, right, I won't use any accommodation.
Very well explained, sir. Sir, let us know more about the treatment or management options of the hypermetropia. Additionally, let's relate refractive errors to the squint or strabismus.
Yes, the mode of treatment in hypermetropia are the same. As I said, that the plus power is less than the normal in hypermetropia. So we have to give the plus power to the patient, right? As our light rays are focusing behind the retina, so we have to converge those light rays to focus on the retina, right? So we need a converging lens, and the convex lenses or the plus lenses are the converging lenses. So they will converge the light rays. The plus lenses or the convex lenses, they converge the light rays and they focus light rays on the surface of the retina, and they will make a hyperopic patient an emmetropic patient, right? So you said that I have to relate these refractive errors to the squint or strabismus, right? So first of all, I will talk about on the hypermetropia, right? And in hypermetropia, there's a term which is called the AC over A ratio, right? AC over A, what is AC over A ratio? It's a type of, convergence, right? What is convergence? When your both eyes converge inside. So this is called the convergence of the, the eyeball. So convergence. So what is AC over A ratio? AC over A ratio, the accommodative convergence over accommodation, right? So it's a type, in which, for example, let me tell you in a very easiest way, what is AC ratio. For example, there are two phenomena inside the eyeball, right? One is accommodation, increase plus power of the lens, and the next thing is the convergence, right? Both eyes, the medial recti muscles are making the eyeball inside, right? They are letting the eyeballs inside. So this is a convergence. So accommodation, increase plus power, convergence, both eyes are coming together. So the accommodation as well as convergence, they are best friends. How? For example, if accommodation perform one diopter of accommodation, the convergence will work 3x, right? So for example, if accommodation is of one diopter, right, and the medial recti muscles will converge both of the eyeballs inside 3 prism diopters. So if there is one diopter of accommodation, there will be 3 prism diopters of convergence. One diopter of accommodation, 3 prism diopters of convergence. So this is called the AC over A ratio or accommodative convergence over accommodation, right? So again, I will repeat this point. If one diopter of accommodation, there will be in a normal eye or physiological eye, there will be 3 prism diopters of convergence. So accommodation and convergence, they are relatable, right? They work together. They are best friend. So if one friend work 1x, the other friend will work 3x, right? So this is a relation between, the accommodation and the convergence, right? So if you are in hypero, right, you are exerting accommodation. And as far as you are using or exerting accommodation, your convergence is 3x. Right? So there is 100% chances in hypermetropia to get the squint of convergence, right? That is called the esotropia or esophoria. So in hypermetropia, the most common squint is, the inner squint, or we call the esotropia. And which prescription should I prescribe to that patient if I'm having, hyperopic patient associated with esotropia? So you have to, or I have to prescribe a full correction to that patient, full plus or convex correction to the patient, so he can avoid accommodation at the distance, and he can easily use that accommodation at the near vision.
So, sir, what about that patient who has hypermetropia associated with exotropia? How should I deal with them?
Yes, you're right, but I think this is very rare condition or rare case in clinical setup, right? So if a patient visits your clinic having hypermetropia along with, associated with the exotropia, as you said, remember, you just go for, a proper visual acuity. You will go for the visual acuity. After that, you will go for the, subjective or objective refraction. But remember, in this case, hypermetropia associated with exotropia, you have to make a patient undercorrect. For example, if patient is having +2 diopters of hypermetropia, if you are prescribing +2 diopters, you have to make it 1.75 less than +2, right? And what is advantage or edge of this? Why are you doing this? Why are you making that patient undercorrect? Why are you making +2 to 1.75? Why? The reason behind that is, remember, when you will make that patient undercorrect, he will make slight accommodation, right? And you know very well, if patient is making accommodation, he will use 3x of convergence, and patient is having exotropia, the divergent squint. So when patient accommodate, he will use 3x of convergence. So that convergence will help him to overcome that exotropia. So you have to prescribe undercorrection to the hyperopic patient if he or she is having exotropia. But you have to prescribe full correction to the hyperopic patient if he or she is having esotropia. So this is the clue.
Sir, you explained hyperopia associated with esotropia and exotropia very well. Now let's talk about the myopia associated with exotropia and esotropia.
The most common, squint associated with myopia is, exotropia, the divergent squint. Why? You know very well, as I said few minutes back, that myopia doesn't use or exert accommodation. Myopia doesn't use or exert accommodation, as I said earlier. So if myopic patient is not using or exerting accommodation, it means there is no any convergence. If there is no accommodation, there is no convergence. As I said, accommodation and convergence are friends. So if one friend is not working, the other friend will won't work at all, right? So in myopia, there is no accommodation. So if there is no accommodation, there will be no convergence. So if there is no convergence, there will be divergence. So in myopia, there is no accommodation. And if there is no accommodation, there is no convergence. And if there is no convergence, there will be divergence. And what is divergence? The divergent squint, right? So this is the phenomena, so that why the exotropia is more common, or the most common in, myopia. So if we talk about myopia with exotropia, we have to prescribe full correction, right? Full minus correction to that patient. So when we prescribe full minus correction, he will totally clear, right, at 4 distance, and he will use accommodation now. And when he will use accommodation, there will be a convergence. And as much as convergence will be there, it will treat or manage that exotropic squint. And if a patient visits your clinic having myopia associated with esotropia, so you have to go for the undercorrection. He will prescribe less minus power, right? Less than the normal. For example, if myopia is -2, you will prescribe him -1.75. And why you are doing that? You are leaving behind a slight myopia. So if patient is still myopic, he will not use accommodation. And if he is not using accommodation, there will be no any convergence. It will avoid that convergent squint. So if you are having, myopia and associated squint is esotropia, you have to prescribe undercorrection.
Thank you so much, sir, for your time. You explained myopia, hypermetropia, and how it is related to the squint very well. If you found this video helpful, please do subscribe Optometry with Khurram. See you in the next episode.